So good afternoon, everybody. I will try to talk you through this interesting topic. Basically, these are my disclosures. You can see the questions I was asked to answer, but I kind of turned it around to what implications can you have if you suspect a polyposis syndrome, and what is important in the management of these kind of syndromes. So I will not be talking about Lynch or HNPCC because this is a non-polyposis hereditary syndrome. I will talk about most other polyposis syndromes, and these are the ones that you can encounter in your practice. I will only talk about the ones that are highlighted in gold because these are the most frequent ones that you can see. But as you see, there's even more to know. So when do you suspect a polyp syndrome? Well, in a patient that has a personal history of 10 or more adenomatous polyps, or 2 or more hamartomatous polyps, or 5 or more serrated polyps proximal to the sigmoid colon. It's a definition that is used very often, but there are others that exist, and you will see throughout my lecture that this doesn't cover the full spectrum. It's also important to know that we talk about a personal history of 10 or more adenomatous polyps, which means that if you perform an endoscopy and you see about 5 polyps, then you may have a patient with you that had polypectomies 3 years before. So please do check the personal history of the patient and not only the colonoscopy that you are performing that day. Then you have a polyposis syndrome in patients that present with different types of polyps. So in conclusion, you really need to make a genotype correlation for the diagnosis of your patient and for the management. Please do not perform unnecessary surgery in patients that don't need it. And you need to know type, number of polyps, so check other old colonoscopies and age of your patient. In childhood, you have to distinguish FAP from GPS and PGS. And in adulthood or early adulthood, you have to check for attenuated FAP, MAP, and serrated polyposis. As GIEQs,
I mean, it's probably better to turn it off, don't you think?
I think it probably is, David. It comes back to my previous point. But if you're going to turn it off, it is an aid. You need to know what you're looking at. And I think you've already made the point through the meeting, previous sessions, that the AI is probably not quite ready for prime time. And this is a great example of why that is.
Or at least maybe we can temper that a bit by saying at least a great example of when you need to know when to turn it off, I guess.
Correct.
Yeah. I would like to involve Triana. We were talking about serrated polyps in IBD before. So what's your opinion on that? Are they frequent or are they?
Well, yeah, in the last weeks or months with David, we did found several IBD patients with several polyps like this, mostly in the left side, and actually the literature is not really clear, so the incidence seems not to be increased. But what is not clear is the evolution of this. So in general, you know, that IBD patients can have a high risk of colorectal cancer of dysplasia through other pathways. So I guess that's the most tricky question, whether these serrated polyps that you may find in IBD, whether they may have other evolution to dysplasia. I don't know if Karen can comment something of this, onto this.
I don't know about serrated polyps in IBD patients, but I do know that, like, from a theoretical point of view, serrated polyp pathway is a one that goes faster to dysplasia and cancer. So, on a background of inflammation, I would not be happy with serrated polyps.
Indeed. So that's the hypothesis, but we don't have still studies. So.
It's maybe Triana, it's also very important to point out how much discussion we've had about whether there is a polyp or not in a lot of IBD cases.
Yeah.
Hello, everyone. I'm Susana Ribeiro, the endoscopist and digestive oncology in UZ Ghent, and I'm here together with the moderators, Dr. John Anderson,